Hi, I'm Ira Kirschenbaum. I am the editor-in-chief of the Journal of Orthopedic Experience and Innovation. We have a wonderful topic now, the expanding world of unicompartmental knee replacements, and a great panel, and some guests, as well as our formal panelists. So I'd like to have them introduce themselves first. We'll start with Marty Redish. Tell us about yourself, Marty.
Yeah, I'm Marty Redish. I've been an orthopedic surgeon in private practice since 1985 as a general orthopedist. So I did trauma, I did everything, I did spine. And in 2000, got interested in partial knees with Rapisi, with the Rapisi movement that was introduced then. And since then, it's been a major part of my practice more and more as I'm a real proponent of doing partial knees, and my goal is to get people to do more partial knees instead of total knees, especially in older people. I've worked with as a consultant for Mako, Zimmer, Biomet, and Max in designing partial knees and instrumentation for them.
Excellent.
And I'm in Chattanooga, Tennessee.
Chattanooga, Tennessee. I could tell by the Bronx accent. It's
Well, I grew up in New Jersey, or I was born in Newark, but
really Newark. All right.
in
Jeb
Indiana.
Broyles.
Hey guys, Jeb Broyles from Baton Rouge. Let's see, I practice at the Baton Rouge Orthopedic Clinic. I've been in practice since 2002 in private practice the whole time. I started right after doing a hip and knee recon fellowship. And that's mainly what I've done since then. My practice is probably 60% hips, 40% knees. And of the knees, I may be on the lower end compared to you, Barty. Probably of my knees, maybe 25% are unis. So, I thought that the title of the topic was kind of interesting because I think it said something to the effect like you don't need a robot to do a uni, I think, right, Ira?
Right.
And it's interesting that it's called that because that's kind of how I got into unis. I felt more comfortable being able to visualize it on that screen before I did it. And really the robot taught me how to do a better uni without a robot and to do it a whole lot faster than I could do it with a robot. So I love doing unis. I love seeing the patients come back to the clinic. It's a great operation.
Yeah, we have Mark Gittens. Mark.
Thank you. I'm a hip and knee surgeon based here in New Albany, Ohio. Interesting place with how unis go. Pretty competitive market. But I'm somewhat like Dr. Broyles. I really pushed the limits using the robotic systems to start with, and it really taught me, became a student of it, of what changes you would make and how they would affect the knee. And so that's what we started with, but now we're pretty much manual instruments, and moved everything obviously over to the outpatient surgery world, which we pretty much do everything at anymore.
All right. So you're mainly manual. All right. We have a number of other people on here, which I'll introduce as the night goes on. Let me start off with some what I feel softball questions. All right. We'll talk about indications for uni. And I want you to think about that question in terms of the slam dunk indication and the expanded indication. All right. Meaning someone else may say, I wouldn't have done a uni, but this is a uni for me. And I'll start with Marty. What your indications for a uni?
Well, I'm going to be an outlier. I do probably 70% unis versus total knees. And I admittedly push the limits of it, and I've been doing that for a long time. I would maintain that I do that because of the type of uni that I use, which is a resurfacing uni, which is removes the least amount of bone and is the easiest to revise. So certainly when I started doing these, I knew that if if things didn't work out well, I could easily do a primary total knee because I use a little inlay tibial component. So as far as my indications, the best patient is somebody over 70 years old, whether medial or lateral. I do lots of laterals, probably 35 or 40 a year, and in big deformities too. But somebody over 70 years old, they don't want to go spend 6 months of the rest of their life having a total knee. They have an easy recovery, so the safety factor is huge. So I've done probably 25 or 30 in people over 90. And it's hard in my book to argue why not to do a uni in that age group, which is something we can all talk about. The very young, say under 55, when I'm using that little inlay component, I know that I can revise that uni. So, and you can revise a uni successfully if you're using one that takes very little bone out. Then you've got enough bone stock to revise it if you need to. And I've got a few of those that I've done over the years, revising the tibial component. And then you've got the people 55 to 70, especially the overweight patients, the high BMI patients. Those, if they're over a 40 BMI, I'll try to just do a total knee. But they're candidates for partial knee too if they've got just unicondylar disease, but they have to know that their chances of doing well are not quite as high, and they might be 80 years old and needing some kind of a revision. So that's not the greatest indication, but basically I'll do anybody that's got unicondylar disease.
All right, Mark Gittens, talk a little bit about the indications.
For me, not quite as aggressive as Dr. Redish, but unicompartmental disease, most of mine, probably a third to 40% of my practices is unis. ACLs, I don't get too nervous as long as the knee is not unstable. So I think the physical exam helps me a lot. So even if you've had an old ACL, but if they're a stable knee, although with pre-certification with the insurance company, that may be a little bit of a dilemma, but that's just something I'm very comfortable doing. The patella, I look at it, but I don't get too nervous unless it's just completely fragmented in the lateral facet. I try to keep everybody under a BMI 40 for that type of the procedure, but that's usually what I'm looking at is unicompartmental disease. If I am confused or the patient's a little bit hesitant, I don't hesitate in doing stress x-rays to show myself and to show the patient this is what we're looking for in the selection of the procedure.
Jeb, well, let's hear what you have to say about this.
So, in addition to obviously unicompartmental disease with pain that goes along with that, although if they've got an effusion, the whole knee hurts sometimes, but the effusion's coming from the worn out side. One of my indications, besides the ones that have been mentioned, is if they have a contralateral, really flexible knee. Let's say their contralateral knee flexes to 145 or so. Maybe they've got 135 on the arthritic side. My experience has been that if I do a total on that patient, that if they're starting with 135, they may wind up with 125. And if the other knee flexes to 145, they're a bit disappointed. So that would be a reason I think to do a uni, so they get that better range of motion. Besides that, as far as what do I accept from the patellofemoral joint, maybe I'd like to see on my exam that they don't have pain with resisted extension directly anteriorly. I think it's important if you're checking that to do it at a bunch of different angles of flexion, because where the disease is may dictate at what angle that extension produces pain. So I don't know that I have a lot else to add that hasn't already been said.
Yep. I'd also like to introduce one of our panelists who came on, Danny Hatz. Dan, you want to tell us where you're doing your great work and a bit about yourself? Oh, you're on mute. You're on mute.
I'm technologically not with it right now, so sorry. Can you hear me?
Very well.
We hear
So
you.
I practice out of Omaha, Nebraska. So I think that's why I was late. I thought this was I didn't know the time difference, so that's my bad. So thank you guys. Sorry I was late. So I practice out of CHI Common Spirit with Creighton University here in Omaha, Nebraska. Started doing unis probably around 4 or 5 years ago. Really liked it. Part of my practice. I think probably 30% of my knee practice right now would be kind of unis right now. And so if I can do it, I always offer the patient. So I missed a little bit about indications, but I would imagine that we all have somewhat similar indications about level of patellofemoral disease and actual symptomatic part of that, and whether to proceed with a uni or not.
Do you have any age preferences?
That's really interesting. So I love kind of talking about unis because of the age thing. I think the old adage was always a uni can be in somebody really young. I've done them, 35, I think was probably my youngest, or lower 30s. I think one thing that people forget about is kind of that elderly population. So I think everybody is a candidate for it. It's a great procedure because the complications are lower. People recover faster. So when you get somebody who has the radiographical, indications for it, that's heck, maybe in their 90s, that's a safer procedure for them as opposed to doing a knee replacement in which they have these huge complications. They might not survive. I had one lady, she was 94 and she had both of her knees and she just wanted to be able to go up and down her stairs. And so, 6 months later, she's got 2 unis on there and saved her a large procedure. And so I think young, old, but in between. So I think there's indications for everybody.
Excellent. Excellent. So I'm going to share my screen for a second because I want to show you something because we're going to get right into robots and no robots right now. So this is a video of me doing surgery. And I just want to show you, this video is, how many minutes long? 26 minutes long, and we only took time out for the polyethylene. Okay, so you can see I'm banging in the implant here. Okay, I'm going to bang that down. Okay, I use an onlay later in career, reach Rapici early. And this took me 26 minutes without the cement. With the cement, that's about 31 minutes. So, and this video got 266,000 views on YouTube. Go figure. People really got to get a life. So I did not use the robot. All right. I used one tray from the hospital, one tray from the company. And I think that's that kind of model. So let's talk a little bit about robot, no robot a little bit. And Daniel, what's your take on this?
So you mentioned onlays. I do an inlay. So I use one burr. We make a pocket, kind of going off of the anatomy, tibial side first, femoral side, and avoid, the 3 kind of mistakes to do, which is overstuffing, lateral or medial tracking of the femoral component. And so, yeah, it takes me a little maybe longer than 26 minutes. I'm somewhere around 40 just because it's a little technically savvy to do more of an inlay. But
yeah, absolutely.
There's lots of upsides that I see in doing that. And if you look in the literature from robot to what you were talking about, it's kind of all over the place. There's a lot about outcomes and things like that. And I think you need to take a step back when you're reading the literature about what it's comparing it to. It's comparing it to a common or a classical uni, which is almost always an onlay, and an onlay, and that's kind of not the same thing. And there's some research about if you are like you, where you can do them in 26 minutes and you do X number of years.
Yeah.
There's literature out there that you're just as good as a robot from getting it perfect. And so what you're doing is with the robot is taking out the outliers. And so I think robots got a great, thing if this isn't something you're doing all the time, just to remove the outliers. And so making sure you're putting in the right. So I think it's got utility to it. But if it's a part of your practice, then, if you can do it right, like you do, and I think like everybody here does, that you don't need it.
Jeb, let's hear from you on the robot issue and the value and what you feel.
Sure. So, I mentioned how the robot taught me how to do a better uni. So let me back up a minute. Before that, I did some Oxford for a while. And the first time I had a poly dislocate, it bothered me so much, having to revise somebody a year after I put it in. It just bothered me enough that I quit doing unis for a while. I got into doing them with a robot. And what I found, it's kind of a small thing, but what I found was that when I did the robot, I always had to take a little bit more off of the posterior condyle of the femur than I thought I would to balance the knee well. And so what I simply do now is when I'm doing an instrumented uni, I take this, flex the knee to 90 after I've cut the tibia, flex the knee to 90, and I shave off the cartilage. So maybe, I don't know, 2 millimeters or so from the back of the condyle. And it comes out pretty much right every time. Before I began doing that too, I had to I'd cut for a 4, for example. I have to put in a 3. But if you do that with that posterior cartilage every time, it comes out just right.
Yep. Marty?
I'm the oldest guy here. Well, maybe I don't know how old you are, Ira, but
I'm 96. Yeah.
okay. Well, I'm 90. I'm 71, and I'm just have trouble getting on a Zoom call, much less using a robot. But seriously, I've never used robots, although I was a consultant with Mako using the robot on cadavers, and was involved with developing their lateral partial knee. I can understand that a robot, one of the problems with the unis is getting the knee alignment properly. In other words, when you resect the tibial surface and the femoral surface, you're sometimes, as I understand it, and you guys can chime in on this, but you're making some judgments on how thick of a poly to use based on ligamentous laxity. And the technique that I use and that Dan uses also, we don't have to worry about that because we're preserving the natural joint surface on both tibia and femur. And we can visually see we're adding a couple millimeters for the loss of cartilage, like a kinematic knee. So by doing that, I don't feel like I need a robot to do that. I mean, Mako, the original robotics, is an offshoot of the Rapisi. That's where that company came from, and that's why I was working with them. And they were trying to do the whole thing robotically, and I just didn't see that it was worth the time and the effort when I was introduced to that. So I've just worked on trying to perfect the technique without robotics.
All right, Mark, some comments on robot to non-robot to robot back. Yeah,
That's good. Yeah. I had my trepidations sometimes. I thought it was a finicky case, first doing it with some of the original instruments. And when I started using the robots, we went through a couple thousand cases, but I really started paying attention to what I would see on the screen. And, you look at the tibia and the depth of the cut and how much you really needed to take, how much you didn't have to take, depending on the wear pattern. So you had depth of cut, varus valgus, the posterior slope. You could see the ligament interaction there as well, especially, with as I mentioned a little bit before, the ACL. So you really can make fine adjustments to really kind of dial it in for that patient. But after a while, you kind of know it, and you can really make the instruments work for you in a manual fashion, where you can dial in those same things, and you get a very good feel with some of the instruments and the gap checking that you can. Certainly paying attention to the posterior aspect of the condyle and posterior osteophytes, cleaning out that posterior recess is important. And maintaining your balance. So that's how we've kind of progressed, and I think it works. I can go either way. And in doing the robots, I think you got to be really careful. Sometimes it may be helpful if somebody who doesn't feel familiar in doing it, but you really got to watch your pin placement, especially in the osteoporotic patient. You got to really be careful with your pin placement, or you get fractures, or you get loosening and erroneous results. So that's what I've seen in that type of patient.
That's right. That's right. What are some of the features you look for? I'm going to go into alignment in a little while, so I want people put their thinking caps on whether you try to get a mechanical alignment or an in situ type of situation. But what are you looking for in an implant right now? And I'll start with Jeb. What are you looking for in an implant and instrumentation, but specifically the implant?
Gosh, let's see. The implant, I like the idea. I like the idea of an onlay, just because it's what I'm familiar with.
Right.
It's very reproducible for me. I like the idea of modularity, because there are times where I may try one thing, and then after it's cemented, I decide, I change it by 1 millimeter. And so I like that flexibility. I think all of the femoral components work well. That's almost never an issue. I think the design of the tibial components now is very good. What do I look for? I tell you, I don't know that I have like specific comments about what else I look for in an implant, but I will say this. I think that having instrumentation that allows you to easily and reliably get all of that posterior cement out from behind the tibia is a big deal. What I've done is I've taken a Woodson and modified it by just shortening it some, because early on when I started to do unis, I had some cement that I thought I got off and didn't, and I had to go back in and scope two people and take out a loose body piece of cement that was giving them a lot of trouble.
Anyone else want to comment on some implant design issues or instrument issues? We got anyone there, Marty? Some instrumentation.
Well, that's something that I've been working on developing, and I did with Max
Okay.
come up with a workflow. The cement thing that was brought up is I've done just a handful of modular onlay standard, what I call resection unis, and yeah, it's harder to get the cement out behind those things than it is for the inlay. Actually, it's a little bit harder to get to. And yeah, I use a Woodson elevator too. But as far as the design of the implant, yeah, I mean, that's a real controversial area as far as a modular onlay, which is the most standard type that's used now for your tibial component, versus what Dan and I are using, which is the inlaid all poly. And we could talk all night about that.
All right. Let's switch. Okay. Yeah, Danny.
Just in regards to the implant, and kind of why me and Marty like the inlay, is if you look at some of the generational, I think we're at like the third-ish generation for unis. The biggest change would be the amount of tibial resection. And I love the fact that the inlay takes so little bone of the tibia. I have a guy here in town. He's not here anymore, but I'm seeing a lot of his old Oxfords, and I'm revising them a lot to totals. And the amount of tibial resection there is pretty big. And that just makes the actual revision to a total a lot more complicated with possibly me augments or just putting a giant poly in there. So it just makes that a little difficult. And there's also, just patient specific stuff for afterwards. I mean, if you're taking more bone, that's going to be a little bit more painful, a little bit hard to get over. So I like the newer. If I was going to do an onlay, I would do the ones that are the really thin ones. I think Smith and Nephew has a really thin one. So less bone taken from the tibia is what I would be looking for a implant thing if I was going to do an onlay.
Yeah, okay. Very good. Steve Gorin, you have a question. You want to unmute your mic and answer the question yourself, Steve? If you're there?
Yeah, I'm here.
Oh,
My
thanks,
question is
Steve.
that have any of you guys use the Conformis customized system? I've been using that system for about 15 years now, and I've had some really nice results. And it's very similar to what you said, very minimal cuts, and pretty much taking just cartilage off on the femoral side. So I was wondering if anybody's had any experience as well.
I'm familiar with, I've never used it. Yeah, it just you just take cartilage off basically from the femoral side. So it's a resurfacing type of femoral component, and then it's made to customize to get a really good fit on the cortical bone on the modular resection tibial component. But I've never used
Right.
one myself.
So I would ask a question about that. I've not used the Conformis Uni, but I will say that has anyone had any problems with coverage on their tibia or their femur requiring a customized, metal that covers that perfectly? And I know Steve would say, well, I'll ask what Steve wants to say, but I have not found coverage issues. Does that, you know what I'm saying? Where I need something customized on the uni. But Steve, what your experience in the Conformis has been just it must be always right on the bone, and tell us a little bit
Yeah,
more.
yeah. So when I was in training, we started with the Rapici as well,
Yeah,
and didn't have such great results in our training. And they were just starting to use the Oxford, so we didn't do a lot of that. But then I found Conformis when they actually had an interpositional arthroplasty that was customized, which was pretty interesting, instead of just a disc. And then I just started using this Conformis because I started to notice that everybody's tibia was shaped differently.
yeah,
And it was just nice when we got it to sit perfectly every time we have cortical contact all the way around.
yeah,
So
sure.
we'd have a 5 millimeter posterior cut on the posterior condyle with just a resurfacing of the distal femur. And if they need to be revised, you can go straight to a primary with almost no issues, with no stems needed. So it's been nice in my practice. I'm not as busy as the rest of you, but it's really helped out. And I do, like you guys said, I've done it from a 35-year-old to a 90-year-old.
Yeah, I can see that having great value on the tibia. Because if you're going to have failure in a uni, we probably could all agree it's on the tibial side. Excluding, of course, extension of disease to the lateral side and that kind of stuff. Let's talk about alignment a little bit, okay? Mark, do you strive for any kind of alignment, or do you do the uni sort of like insight you and just what the ligament there allows you? Let's just talk about a medial uni for a second. What the medial collateral ligament allows you to put in. Or do you strive for some type of alignment?
Yeah, I'll answer two things there if I could, Ira. So on the
Yeah, sure.
component design you mentioned, for me on the femoral component, I do look to make sure I have two lugs. I think that's important on the femoral component to cement that in and try to stay away from one lug. I think we've obviously seen failures there. On the tibia side, I like to have variable sizes because that's where the variability between femur and tibia tibia is a little bit more variable. I'd like to see a keel and then a drill hole on the tibia to cement those in. So I'd like to have both of those on the tibia. So that's what I'm kind of looking for is modularity, and then having that type of fixation on both sides. As
Great.
far as alignment, I try to keep it. I try to kind of keep it in situ. Starting with the robots for that much time, you can see the ligament and how it balance. So, in trying to instruct on that in the past, I tell people don't get numberitis. If you do have a number, don't chase numbers. You really want to fit that for the person and what their ligament construct will accept. We all know if we overstuff, that's a bad thing. So you want to stay away from that. But certainly trying to fit where they normally is. And some people just have some constitutional varus. And if you've established that and they don't have pain, I think we're all happy there.
Sure. Jeb, some comments on alignment?
Yeah, no, fine. It's fine to leave them in a little bit of varus if they started out that way. Obviously, not a whole lot. I would say, maybe one. I don't know if it's exactly what you're asking, Ira, but one contraindication is somebody that's in varus, but they've got some translation already of the tibia on the femur. For me, that's not somebody I want to do a uni in, just because after you put the trials in, it's still going to be kind of tracking off to the side of the poly.
Yeah.
I don't know how to, fix that properly in my hands unless I go to a total. But no, it's fine to leave them in a little bit of varus or valgus. You just have to balance the ligaments to where they have good range of motion and the knee feels right, that it's not too tight.
Dan?
I kind of agree with that. It's, you make your ligamentous stability in situ or intraoperatively, and I always get an x-ray afterwards, and reliably they always kind of correct themselves when you're looking at it post-operatively when the wound's closed and you can't do anything, to about 2 degrees varus almost every time, and that's just based off your in situ things. That when I first started, I was really worried about this, and so I would put my trials in and I would get an intraoperative x-ray. And then once I just felt more comfortable with it, I do an x-ray afterwards. And then they were always, right on that line where 2 degrees varus. And so it's all in situ. It's there.
Yeah. And I always think it's important to keep in mind because a lot of the robotic people say they can get the alignment right. And I'm thinking, what are you talking about? Yeah, I want to know what are you talking about when you say that? To me, for me, it was always an in situ procedure to a large extent. There was a newscaster in New York who used to say, "Let's go to the videotape," and I have a couple of X-rays here. I want some comments from people. These are Marty's X-rays. Okay. Hold on. I'm gonna show a couple of these of Dr. Redish. Let's get some pre-op. Here we go. Let's start with this one. I like this one. Can everyone see this X-ray that says stress?
Ira, what I would love for you to do is go back to the pre-op before the stress.
Okay, this one?
Yeah.
Okay.
So that's where, as I said, I've kind of pushed the limits of these things, and Jeb would be afraid to do a partial knee on this because of the subluxation translation that you see there. But what I've found is that it just seems to correct. So if you do the stress view, and if you can show that one you were just showing that says stress view, it should be just adjacent to that.
It's right below it.
Yeah. See what happens with just a valgus stress? That subluxation is gone. And then, so I did a uni on this guy, and there it is. So it's not because, I figured this all out. It was just trial and error, to tell you the truth. And I found that I'm not afraid of the subluxation anymore. If the stress view, if it corrects with a stress view, all I got to do is put some implants in there, and it seems to hold it in good shape. And these people have done very nicely. So I have not seen a problem with subluxation. And I was going to say, as far as the alignment that we were talking about, that I would agree with Dr. Gittens as far as, it's kind of a kinematic knee type thing. You just want to get them back to their native alignment. Usually that's 0 to 3 degrees of varus, but, not always. If somebody's got a native alignment of a lot more varus, we'll just get them back to their pre-disease state.
Any comments from the faculty on this?
Yeah, I've got a question. Go back to the X-ray before. It's number 6. So yeah, Marty, that's a great case. That looks wonderful. So when you get a stress X-ray, you know how sometimes like on the X-ray before that even, you would have seen that the tibia spine is impinging on the lateral condyle.
Right.
Okay, whereas when you go to the next X-ray, it's no longer impinging. If you saw that even with a stress X-ray, there may still be some impingement of that spine on the medial aspect of the lateral femoral condyle, does that worry you? Like, I guess, what's the limit of what you're gonna? Where do you decide? Now I just need to do a total.
Well, again, I initially for the first 10 years of doing these repeats, I would scope people first, and I never published anything on that, but I would make a decision whether to do a uni or a total. And what I found was that in somebody like that, they're almost certainly going to have some grade 4 changes close to the notch from that subluxation. But when you prop them up with that inlay, or with the uni rather, you're getting the contact off of there. So if the other 3/4 or 7/8 of their surface is in good shape, then you're going to be all right, because they're not going to feel that. But your question is a good one. In other words, this guy's lateral side close to the notch is probably going to be worn down, and I would bet you that it is. But my experience has been it typically doesn't matter because we're getting them off of that bad area where it's impinging. So I can't say that it's not like I've done a lot of these that are sublux like that, but I've certainly have done them, especially when the patient really wants a uni. And I don't scope them anymore because the thing that changed my approach is the realization I can do a uni on the lateral side if the other side ever wears out. And some would debate whether that's as good as a total knee. And in fact, there's some literature saying it's better, a little bit better than a total knee, a uni on both sides. So, so
who would ever do that, Marty?
Just a fanatic uni guy like myself would do that. So
I did review your X-rays before, so it's
yeah. So that's what we have there, and I went to a partial knee meeting in Europe in Bruges, and this was what they all did. If they had progression of disease, they did a uni on the other side. That was just standard practice. And since 2017, that's what I've done. I probably got I'm thinking about 18 or 19 that I've done now, and knock on wood, they do beautifully. And a week later, they're running around. They haven't had to have a conversion to a total knee.
Let's look at this one.
Yeah, this is pretty. This I just like to show people because they're freaking out a little bit, because this is like a 50-year-old guy that worked in a chicken plant down here in Chattanooga. They got a lot of chicken plants. And I did do a hip replacement on him also. And I was worried about that big cyst there. And I guess I should still worry about it, but he's a good 5-6 years post-op. But see that big indentation there? And that's his post-op. See, so he did a lot of my inlay work for me already. And what I've found on these big deformity laterals is it's usually kind of central where their depression is. It's not posterior. It's rarely posterior lateral, which is what Rapisi said it was. It's usually central, so I can just carve around there and use usually a thicker inlay, a thicker poly, and correct that pretty nicely. So those big deformities, first of all, they correct almost always with a stress view. So you don't have to release anything laterally. And if you just fill in that divot, obviously with a little more trimming, and cement something in there, they've done great. And laterals just it's a great operation. They don't seem to hurt under the implant, and they don't seem to loosen or anything. The only laterals I've had to revise is for progression. I've had I think 3 of them over the years.
Any comments on this? What about this cyst? He's had it for a long time and he's dealt with it.
Yeah, I don't know. I was worrisome, but I guess it's never bothered him. So I'm not saying that a person should say this is what we're going to do on their oral boards or anything, but that's just what happened.
Well, you're still going to have the cyst problem if in the total knee.
Yeah, I suppose so.
Yeah. So any comments on this? No, we're good.
Pretty crazy.
Yes, really is.
That first X-ray is so impressive, and then the way it looks right now is great.
It shows you. It looks like this lateral condyle
Flat.
is so bad, right, Danny?
Mm-hmm.
And then when it's replaced, it doesn't look quite. When it's aligned, it just doesn't look quite as bad.
Looks beautiful. Yeah.
Yeah.
Marty, post-operatively, do you get a notch view for that? It just looks so bad preoperatively. I wonder if the notch would look. But he wasn't painful immediately, though, right?
No, he wasn't. God knows why I ever decided to do that. I can't remember that discussion that I had with him. And like I say, I quite honestly, I know I'm pushing the limits, but I know that's easy to revise if it doesn't work. And I've just been getting away with it for a long time, and it's just worth sharing those experiences with people.
Sure. Let's look at this one. Not this one. This one.
Yeah, that's a post-traumatic old, elderly lady, skinny, and she had lateral compartment disease, lateral pain, and that was just a good example of using this minimally invasive to bone implant and just working around the screws. That's the post-op. I had to take one screw out, which I could do through that same incision, because the central peg, the one central peg was going to hit it. Of course, this implant doesn't have 2 pegs to control rotations, but it's got a keel, which controls rotation and also strengthens it. So you can use a thin 2 or 3 millimeter resurfacing femoral component instead of a 6 millimeter, which you have to use with chamfer cuts.
Excellent. Think of what you'd have to do to put in a total here.
Exactly. 2 stage.
What you'd have to remove and how you'd have to protect her. You know what I'm saying?
Very rewarding to see her walking around a week later, like, she did particularly well, better than most. So yeah, it's pretty cool. It's a nice tool to have.
Yeah. No, absolutely. So I'm gonna stop my share here first for a second, and go back and ask a couple of questions. I think it was Mark, you talked about your requirements for 2 pegs in the keel. And is that why you use the Freedom partial knee system too? Because it has that.
I want to control rotation.
Right.
Yeah, so that's the biggest part of it.
Yeah, because I've seen the triathlon does not have a keel, It's kind of an interesting, very interesting design, with the 2 lugs, the keel, and the Yeah, I'll share my screen again just for fun. You guys can see this? The keel? Yeah.
I don't think that has a keel, does it?
What is that?
Guys, that you're using that resection freedom. That
What
I
is,
think it's got
what
two
is
pegs.
that piece here?
We have two unis. This is
Oh,
one
the
of the,
tibia. I'm sorry.
right. We
Sorry.
also have the old poly one, Ira.
Yeah, that's here, right?
No, that's still there's another one that we have.
Oh, yeah. So hold on.
This one is an instrumented one. The other one we have is with birds.
Okay.
I'm sorry. I thought you were talking about the femoral component.
No, I'm talking tibia.
Okay, sorry about that.
The tibia. All good. I think that's a really nice feature. Now, of course, I always like to say this is the Joey open mic night is always the fastest hour in orthopedics. All right. Most of us could get Charlie the cook could get 3 joints done by now back on the pickleball court. So we all know that. But I want to push on one other topic, which I think is important. A certain number of knees, total knees, partial knees, x-rays look great, alignment looks great, but the patient's in some pain. Okay. Now, one of my colleagues said this at a meeting. He said, when you have a uni and it's painful, everyone says it's because the uni, they replace it to a total, and then they end up getting a painful total. So what is your after you've ruled out infection? What could be? How do you address a painful partial? Okay, X-rays look great, everything looks good. We're 8 months out, no infection. Dan, you want to give me a couple of comments on that? Because we have these patients, we have them in total knees.
I mean, those are always hard. Rule out infection. I had a couple, or I had one that I can remember, and it turns out he had a torn ACL, and he was just super unstable. And so I ended up converting him to a total, just because I'm like, you're just not going to get better. I'm not against doing like the smallest dose of steroid, like an injection, just to maybe calm down the other cartilage. It doesn't make me feel good, but I've done that a couple times, and patients get better of just like some chondromalacia around because usually their pain's a little bit more generalized. Very rarely do I have pain over the implant, and then I'm more worried about loosening and things like that. Even if radiographically they look fine, I'd get like a more advanced study. So usually it's more generalized. I'm not against doing an injection of steroid because 80-90% of their knees still normal, and then they usually get better. Occasionally I'll get an MRI if I have concerns about ligamentous stuff like an ACL, which has happened to me before.
Jeb?
Yeah, so I'll tell you 3 kind of interesting cases that I learned from. Okay, one, a patient with tibial pain. The X-rays looked good at 6 months. The X-rays looked good at 9 months. X-rays looked good at a year. But somewhere around 18 months, she started to clear. The tibial component was clearly slightly loose and beginning to subside some. So it's not all in that case. It was not apparent early on. Another case I mentioned that cement. So I had a patient that had started to have lateral pain, and man, you had to look close at that X-ray. But if you looked at the early post-op X-ray on the lateral view, and you looked at it again later, that little piece of cement that was behind the tibia was gone. And then if you on the AP, if you looked really close, you could see a radiodensity down in the cartilage of the lateral tibia condyle. So I scoped her, and sure enough, it was literally impaled down in the tibial condyle. Third case, I can't remember what the third case was now. But let me think. It may come back to me. But I think a painful uni like a painful total, although arthrofibrosis is way less common, I want to know, what was their motion pre-op? What's their motion now? How much flexion does their other knee have? This, I think, applies more to totals, but routinely, if I have somebody that's not real happy with their total knee, maybe they've got 115, 120 degrees, but their other knee flexes to 140. I'll do a manipulation on those patients. See if they show up in my office 3, 4 years later. I'll do a manipulation. Usually you can give another 10 degrees, and look, they're never going to be totally happy with it, but they're happier than they were. So that's my 2 cents.
Mark, some comments on that? Painful knee?
Oh, those are great. Again, I would reevaluate for the instability. I think that's something, and even including repeat stress X-rays, obviously infection. On the cement issue, I had some issues, and a couple of my scrubs were getting a little bit heavy-handed with the cement on the posterior condyle, the femoral component, and that was giving me a little bit more trouble than I wanted to deal with. So again, watching the cement. And the last thing that I've had is sometimes it's neuritis. You got to look for other causes. Sometimes it's their back. They've been on the walker too long. Their back can do it. And even have the anesthesia colleagues try some superficial nerve blocks sometimes it's just a neuritis that is causing them. It's not your implant. If they've had pins in the bone, stress fractures around the pins can cause that subluxation of the tibia component, what I've seen as well. So those are the little things that run through my mind.
Yep. And Marty, some comments. You've done a lot of unis.
Yeah, so I've seen some that hurt, obviously, and using the inlay, one would think you'd get a lot of a higher incidence of pain underneath the implant, since it's not sitting on any cortical bone. So the percentage of that is really small, but definitely have seen it and have to deal with it. And I've dealt with it by I've done some subchondroplasties underneath the poly inlay if I think that's where their pain is coming from. And that's worked pretty nicely. Being patient with it is what most people will say to do after. I don't have a good feel for how many resection, onlay, modular, how much medial pain people have, but they say, the Oxford people anyway, that they can hurt for a year or two and just wait it out, which is a little harder to do in America than the polite English people that will be that patient. The neuritis thing, yeah, the saphenous nerve, that anterior medial incision, I've seen definitely some people hurting because of a neuroma in that area, and I'll inject them. And I've even on a few of them just made a little incision and removed the inflamed nerve ending there, and that was curative. So yeah, you gotta make sure you're not just dealing with a little saphenous nerve issue there, for sure.
So I think Jeb's senior moment has gone away. We have a third unusual case, Jeb.
Yeah, and this gets back to when I was doing robotic unis and kind of chasing the perfect graph of ligament balancing. And I had a case where the posterior slope was probably greater than it should have been. And I think the patient hurt because of some instability because of slightly excessive posterior slope. So something else to look for in a workup.
Excellent. I want to share my screen one more time. I want to remind people this is a shameless plug. At the Academy meeting this year, the journal, JOEI, is going to have its annual mixer. Everyone's invited. Everyone's invited. Device companies, reps, all kinds of people in New Orleans who don't belong there. They're all going to show up. Everyone's going to show up. So we're having at the Vintage Rock Club. Just keep your eyes open for emails, which come incessantly to you. I would just like our panelists to just go around and just say just 1 minute or so, a little summary about some advice to young surgeons doing saying I want to start doing unis? That's my last question. Just think of some advice to some young surgeons who say, I didn't really train that much in unis, but I really want to start doing it. Marty, let's start with you.
Well, what I would tell them is stop doing total knees on old people, especially 75, 80 years old. You're doing them a disservice because you don't know how to do a uni. It's such a clear-cut indication for it, and you just hate to see these people suffering through a total knee when they really don't need one. That's find a uni that you can do, and because I think we owe it to those, especially the elderly patients.
Yep. Dan?
I can't, me and Marty have been working together for a little bit, and so I can't agree with him anymore about, the rate of complications, whatever they are in the elderly population, and trying to minimize that, especially if they radiographically or have great indications. So, but to people who are trying to get into this, my best advice would be not to be afraid to try something new. I get a lot of colleagues that I have, they're like, this is how I was trained, or I wasn't trained on doing a uni. It just takes a little bit of effort to do the research, get comfortable with it, find somebody who can teach you a good technique. I found Marty probably 5 or 6 years ago through a friend of a friend of a friend. And I went down to Chattanooga for a week, and I studied, how to do it. We kept in contact for my first couple. So that would be my advice, is just find a way to do what's best for your patient and become an expert at whatever you choose to do. So it's not that hard. You just got to have the balls to do it.
Yep. Jeb, some comments?
Yeah, so there's so many good cadaver courses to go to. Those are helpful. Once you start doing them, get your rep to maybe get a couple of cadavers and practice that. Just like Daniel said, have a partner scrub with you or a colleague. And one thing that I would just say from a technical standpoint that you have to really be aware about when you're learning how to do a uni is you have to know that you have to realize that when you're putting a Hohmann retractor in there, for example, and using that to sublux the patella, you're shifting the relation of the tibia with respect to the femur, and you're going to end up cutting your tibia in the wrong place. So I'm sure that's been, look, I don't have any original thoughts. If I do, it just means that I'm not reading enough somewhere. But that's just something that you really need to watch out for.
Mark, you want to bring us home on this issue?
It's like any other procedure. You need to perfect your craft and go to a course, get a mentor, get someone you can call after the cases as well, because sometimes you can decompress. When you really have finished your cadaver work and you start doing them, the best thing, do more than one case. I think we all try to just do one case, and you're rusty by the next time you do the case. So if you can stack the cases and do 2 or 3 the first day, you'll be surprised your learning curve, I think, goes down because you just don't forget as much, and your staff is better at it, and then you're better at it as well.
Yeah, and I'd like to just personally echo the comment that Dan made on traveling to other places that do it. There's nothing like going into someone else's OR and watching them do it, and then going to dinner with them afterwards, and talking about the details you saw. It's really invaluable. The companies run amazing courses. Speaking of companies, I want to thank Max for sponsoring this tonight. A superb company with superb products, and they run courses, people run courses. You can never get too much education, but trust me on the travel. I want to thank all the panelists for tonight. This was really a great session. It's our first one for 2026. We're going to have 30 more, not exactly like this, but we'll take it from there. So from that, I'd like to say good night.